All right, part two of Unit 2 Indications for Infant Studies and Pediatric Hookups. We'll discuss the different reasons why, or indications for, uh, children coming into the sleep lab. We'll also talk about the differences in a pediatric and adult hookup. There's not too many, they're pretty similar. One of the biggest reasons infants come to the sleep lab are for sleep related breathing disorders, SRBDs. These can include if someone thinks they're not breathing or a suspected apnea, if the parent or guardian thinks the patient isn't breathing properly while they sleep, maybe it's not rhythmic and it's kind of weird. They might think the patient has really bad GERD, which would gastroesophageal reflux, uh, and that can actually be a symptom of obstructive sleep apnea. Um, Presence of congenital malformations to the head, face, mouth, tongue, neck, or chest. Think Pierre Robin or Treacher Collins. All these things can cause obstructive sleep apnea because they get in the way of the airflow. Uh, the patient could have indications that lead providers to think that they have suspected central hypoventilation syndrome, which means the brain is not telling you to breathe enough. Congenital neuromuscular disorders associated with generalized hypotonia. Hypotonia meaning low muscle tone. And post-operative evaluation of infants who have undergone surgery to the face, mouth, and neck, which can exacerbate apnea. Otherwise, the patient may have a suspected seizure disorder, which a full head hookup would be used. Anytime you hear congenital, that means you're born with it. And some of these congenital facial issues, you might have heard of like a cleft palate. The post-operative evaluation, that's after they've gotten something fixed. Doesn't mean that their sleep apnea is fixed. It could be worse sometimes, especially with adults. Uh, you don't really want to take their tonsils out, even if they have the big tonsils, because even when you take them out, that's gone. But where the tonsils were, you have uh, this extra tissue, and it's scar tissue, and it's tonsils are very soft. We call it soft tissue. That tissue becomes really hard and difficult to move when it's scar tissue. And if that's big enough, it can make it even harder to treat sleep apnea. To ensure the best possible outcome for your pediatric sleep studies, you should prepare yourself mentally uh, and physically. Allow the patient and their guardian to follow their regular routine when they are at the lab, like reading or co sleeping. Approach the scenario as you would as a team, but don't be afraid to delegate duties to the parent if they're willing. The team consists of you, your patient, and their parent. Everyone has an active role during the study. Your job is to put on the wires and make sure the study runs well. The parent's role is to keep the child comfortable and help create a positive environment. And the patient's job is just to hold still long enough and keep the wires on. Let the patient pick which sensors go on next, or let them choose the color of the next EEG wire you use. Let the patient put a wire on at all. Participation gives the patient a sense of control. Be mindful of the language you use. We're going to use stickers and lotion or a fun scrubby paste to put on these funny wires. I don't think I ever used the word electrode in front of a child. I don't even think I called them electrodes in front of adults. They just don't. You don't have to say that. Uh, some labs may have some distractions in the hookup room. TV and movies are generally the best, something that gets them to look forward to. If the patient is looking at a book or a phone, they may be looking down, which can make the hookup harder. You're only accessing the O's, and you have to really maneuver yourself. That comes down to what you are going to do as a technologist. Are you the kind of person That's going to say, okay, please look down. All right, please look up. And I'm going to have you do this, I'm going to have you do that. Or do you work around the patient? Whatever they're doing, you bend over and go do some yoga to put everything on around them. I'm a pushover, so I was the second person when it came to patients. I would do whatever to go around them. It makes things harder, but you're trying to do the best thing for your patient and yourself. So everybody's different. Throughout the time, remind the child a lot that things are coming. Like, remember, when I get back, we'll put on these silly wires, then we'll come back to your room. Remember, when I come back, it'll be time to lay down and go to sleep. If you warn kids ahead of time, then there's no surprise. Read the room, know your audience. If the child is interested in a positive way in the study, let them know the lighter things about sleep and go from there. Use your judgment in knowing when to hold back. At the end of the day, you need to realize that these children aren't your children, and you can only do so much. You can't really discipline them, right? Some old school technologists I know will sometimes they'll use what they would call a gentle head hold to get some wires on if the patients are really going crazy. But you really have to read the patients and know what they want. I've had the situation where the parent has wrapped themselves around their, 7-year-old child, holding their arms and legs down, while I feverishly glued wires to the patient's head while he shook screaming for 30 minutes. The rest of the technologists waited for me because in the hookup room it would be 4 people could go at one time, but no one wanted to be in there while that kid was, screaming. And the whole time I kept asking and telling her, the mom, that we could take breaks, or I'll go until you tell me to stop. Ended up being fine in the end. I was a little shaky. The adrenaline had gotten to me. But you also have to be mindful of your other patients and the other technologists you work with as well. Some patients have zero tolerance for crying children. When my baby was born, she's 4, she's almost 5 now, but when she was born, that immediately triggered this thing in my brain. When she cried, it was automatically, it's the worst thing that's ever happened in life, and I've got to go see what happened. And that's what it's like, me seeing kids cry a lot. So I try to avoid it. But you got to know yourself. Know how far you can go before you become triggered into being irrational or unprofessional. Encourage the patient and the parent to make the sleep study as close to a normal night as possible. That routine thing I was saying. Try to prepare for bedtime proactively. Have the patient come into the lab with their pajamas on already. Special note, do not let any of your patients wear onesies, because you've got to if you know what a onesie is, everything kind of zips up the front, and that's what you wear. When we're putting things on the legs, those things have footies, so you can't get to your legs that way. You've got to unzip that thing. That's not flattering. So onesies are not great for sleep studies. You're going to expose the child. Anyways, let them eat a small snack. Bring in their favorite books. I've had many parents sing their children to sleep. Some breastfeed to sleep. I would say at least half of the parents that slept in the same room as the patient co-slept or shared the bed. There's a real push against co-sleeping in the current general pediatric arena. If you have a child and you have a checkup, they'll ask you if they slept when they are an infant. Do they sleep in their own crib? They are incredibly afraid of suffocation, mainly from a parent rolling over on top of the infant. This does not happen in reality, with a couple of exceptions. One, if the parent is an alcoholic or takes narcotics and they have a decreased arousal mechanism and they can't wake up, well, then, yeah, I can see how that could do it. That or some other sleeping disorder where the parent might not be able to wake up in time to stop their violence in their sleep, that could be another thing. Co-sleeping with infants usually involves a bassinet that kind of hooks onto the bed with a seamless transition, or they just sleep right in the bed and there's strategically placed pillows or sections around the infant that they can lay away from loose sheets, pillows, or blankets. Co-sleeping is probably most likely the safest way to sleep in the sleep lab, especially with the tech closely watching. There are some theories that co-sleeping can lead to dependence, but a lot of parents who co-sleep are also parents who are trying attachment parenting. And that's the idea that the child will leave the nest when they are ready. We did this with my 4-year-old. In fact, she decided to sleep in her own room last year, but now my wife is suffering because of it, because she likes sleeping. She likes having her sleep with us so she doesn't have to worry on the monitor. But Clara likes sleeping with us, and honestly, I wouldn't have it any other way. A lot of couples may struggle with co-sleeping, especially husbands. They feel like they're losing their partner. But it's all going to be up to individual needs and capabilities. Most times you can trust the parent to help you out. Parents are usually around their children the most, and they know them the best, especially infants and toddlers. So everyone's got their job, and they are all equally difficult. Technologists are there to put the wires on and produce the best sleep study possible. The parent is there to comfort the child and keep them as calm as possible. Parents can have an incredibly calming influence, and you can use that to your advantage. Maybe have the parent put some of the wires on, especially the cannula. That's the one that everyone hates, especially the kids. Especially if you have to use two, one for nasal pressure and one for end-tidal capnography, which is CO2 collection. The child just has to lay still and try not to shake all the sensors off. But children don't have impulse control. When they see something shiny, they grab it and they eat it. Depending on their age, you can encourage the child to be an active participant in their sleep study. Children are naturally curious individuals, and they are curious about what's going on them. Show them all the wires and let them pick some of their favorite colors. Let them choose which sensor goes on or which color goes next. Get them to click their effort belts in, or plug in some of the wires into the head box. Obviously, if the child is really upset, you can try these things, but it doesn't always work for everybody. If there's a treat or prize later on involved, sometimes a child can hold it together. If there's a treasure box, that's a big win for a lot of kids. You could also have a puppet or a doll that's being hooked up, or has a way that the child can tape on wires to a favorite stuffed animal or some spare stickers, electrodes for their parents. Children don't always respond to or understand teasing or sarcasm or being funny, so take their age and any diagnoses they have into account. Typically, not everyone, but typically autistic people usually take things very literally. It's a good idea to be friendly, but not exactly so jokey. Kids, you can have fun names for your equipment. Maybe your head box's name is Shannon, or your snore microphone could be Snoring McSnoreface. If you can, read their face and their body language. If they seem like they're into what you're doing, then lean into it. If they're afraid, try and get them distracted with something else. Ask them what they like to do for fun at home. What movies are their favorites? Anything to get their mind off what's happening right now. The best distraction methods are usually movies, depending on the scheduling and timing. Movies might be too long, though, especially if there's not a TV in their room. But I've found TV shows with small episodes like Bluey or Peppa Pig. They have 7 to 8 minute segments. Personally, I love SpongeBob. 12-minute segments. With the commercials, I can get a kid hooked up in an episode of SpongeBob if they cooperate. Sometimes the parents or maybe the physician doesn't want the patients to watch TV at all. In that case, have some books or a radio for some easy listening. There are some good YouTube channels with read-aloud books that you can listen to, too. I've seen an EEG lab that has a distraction box with fidget spinners and bubbles and pinwheels and other little hand puzzles and things to keep kids entertained while they wait to get hooked up. All kids are different. An 8-year-old doesn't always act like a typical 8-year-old, even if they aren't diagnosed with any disorders or conditions. Some kids break down when they get stressed, especially around their bedtime, which is when the sleep study is going to happen. Be sure to use a lot of words that describe the timing of things. First, we'll go into your room. Then we'll go to the hookup room. You'll have enough time to finish this episode. Then we'll go to bed. Give them reminders of when things are going to happen. Kids need warning before they need to do something because transitions for them can be tough. Also, use sensory words, like, when we take the tape off, it won't hurt, because I will use adhesive remover. When you leave the lab, you'll probably be a little sticky. The scrub I use might feel cold or scratchy, but it will not hurt. Let them know what to expect. If you forget what it feels like to be scrubbed, remind yourself and do it on the back of your hand. Try to be aware of everyone's personal limits. Regularly ask the patient and the parent if they're doing okay. They might be fine 1 minute and the next they have a tear rolling down their cheek. Try and get the parent to distract the child. If you need to remember to breathe. If you're having a super hard time, but you know a technologist who is super great with kids, watch them for tips or ask them how they deal with it. Hopefully your policy and procedure manual will have something in the way of limits children are expected to handle if they are absolutely losing their mind. Even not just kids, but for the first few hookups you have in the professional world outside of clinicals, but when it's your job, you're going to sweat and you're going to shake while you're hooking these people up because you haven't done it enough. Even after your clinicals, it'll happen for a couple weeks, maybe a month. It happened to me. Even when, after 5 or 6 years at Raleigh Neurology of hooking patients up, I was a master at hooking up there. And I switched over to managing a job in Fayetteville. New lab and new stuff. I was shaking. I really was. So it doesn't matter who you are. The adrenaline will kick in, and when that happens, remember to breathe. For the majority of the hookup, all the wires go on just like they do adults. You can even use collodion, the special super glue, as long as you're careful not to get it into anyone's eyes, or don't use it on anyone who has asthma. There are a couple differences, which include the chin EMG. Instead of separating the two wires 2 centimeters apart, we're going 1 centimeter away. Sometimes they get more leg and arm EMG wires. Sometimes it's good to investigate developmental progress and an arousal disorder. The maturation of gross motor, fine motor, and phasic motor movements during sleep can be a marker for neurological development. Abnormal arousal responses might indicate an underlying problem with the central nervous system. Prolonged sleep without arousals or body movements or position changes is a sign of abnormal development of the arousal response. What does that mean? Holy cow. When babies grow, they don't have this thing called the arousal response. You've heard of SIDS, I'm sure, sudden infant death syndrome. That's when babies stop breathing when they're sleeping, and their brain is not telling them to wake up. Their arousal, that's what wakes you up, is an arousal in your brain. And they don't have it. Some don't have it, or it's not developed yet. And so they could be having a central apnea, most likely a central apnea, or they're hypoventilating, and an arousal doesn't wake them up, and they die that way. So this is talking about how with growing bodies and muscle development, you can have these extra wires on and see how often do they move, and does it wake them up, and how often does that happen throughout the night. That can show you how well they arouse. If they don't move a whole lot, that could be bad because they're not waking up enough and to potentially save themselves. The eye locations, or the EOG, they're the same as far as where you place them in accordance to the outer canthus, the outer point of the eye. However, we're changing the distances from 1 centimeter out and down or up to half a centimeter down and up. Infants may or may not be able to move their head very much, but you can very gently support the opposite sides of the head when you're scrubbing. Use the most care when scrubbing around the eyes. For adults, the polarity of waves of EEGs, if the going up or down, depends on the difference between the retina and cornea. When we put wires on your eyes, the reason the signal goes up or down is because of the retina and cornea in your eye. When babies are premature, it's harder to notice that because they don't have the anatomy that we do. It's not as robust. It's not as developed. So they show weaker polarity. So they don't show the signals as well as adults. If you even look at an infant long enough, they don't really roll their eyes to see anything, and they don't blink much. I remember when my baby was born, she didn't blink at all. She just stared. Retinal development in the eye involves migration of the vasculature from the regions surrounding the optic disc toward the periphery, as well as the development of the central control of the eye movements. This means that the blood supply vessels, the blood supply around the optic discs, are growing out and they're branching out. And this will allow the baby to better control their eye movements later on. Because of this, if you see infants closing their eyes, that means they're getting sleepy, because these are voluntary movements, involuntary movements when they're slowly closing their eyes. Later on, they will have more voluntary movements like blinking more. Some underdeveloped infants may show saccadic and disconjugate movements. Saccadic meaning jerky or rapidly moving, and disconjugate meaning moving in different directions, kind of like a chameleon. They can be looking one way and the other way. Once the anatomy around the eye grows and develops, it'll be able to control the eyes and lids better. The EKG, or heart wires, are placed in its regular place, and EKG placement will differ from lab to lab. I've worked at a lab where you put 2 electrodes on the front of the chest. I've worked where they let you choose, where you put it on the right electrode on the back and the left electrode on the front of the chest, or even the bottom side of the left rib. A lot of places use 3 electrodes. Bottom side of the left rib is a very ticklish area for children. Another way you can get an EKG rhythm is to place 1 EKG electrode on the center of the chest, which we would consider mid-sternal, and reference that electrode to M1 or M2. Even better, you can add another channel that connects M2 behind your right ear to one of the left leg leads. And this is an actual EKG derivation called a limb derivation. and it's going to give you a great QRS wave. Some patients are also equipped with a Holter monitor, which is just an EKG machine that stores cardiac data for 24 to 48 hours. It's indicated when infants are thought to have cardiac issues, which we should remember they are kind of rare. When we look at the EKG, it's the electrical signal through the heart, not the blood flow or anything like that. The EKG can suggest if the flow is correct, though. As for all pediatric hookups, you use an oronasal thermal sensor or thermistor to measure apneas. That means when you breathe out, it's hot air. When you breathe in, you're breathing in cold air. You've got that little thing that sticks out in front of your face. When it's hot, the signal goes up. When it's cold, the signal goes down. That thermistor, remember thermal, thermistor, that measures apneas. A nasal pressure transducer measures hypopneas. That's the cannula. Infants typically breathe through their nose unless they're sick or they have some sort of defect. Pulse oximetry, thing that goes on your finger, measures your oxygen. They make a bunch of different probes, the thing that sticks on your finger, and connectors that hook into the machine that can fit on many different tiny body parts. They have some for fingers, toes. You can even clip some on the earlobe. It can be difficult to monitor an infant's oxygen. So always make sure the probe is on correctly. If you're unsure of an oxygen reading from the sleep software, get another pulse ox from somewhere else, like an external one, and use that to see if you'll get the same percentage. For respiratory effort, seeing if they're trying to breathe, the belts. You're almost never going to deal with esophageal manometry in a private lab unless you are dealing with very specific patients. It's still less likely in a hospital, especially for just respiratory monitoring. But esophageal manometry, if you think about it, esophageal, down your throat, manometry, taking a reading, and it involves placing a tube through the nose down the back of your throat to the sphincter muscles, which will show up when they open and close the airway. As you can imagine, it's probably uncomfortable. Imagine trying to sleep like that. I have actually heard of labs who use those, but it's for gastric reflux. Anyways, the standard for respiratory collection are the respiratory inductance plethysmography belts, or RIP belts. And you usually have some pediatric belts, they're tinier. These belts have a wire sewn in going up and down the whole length in little waves through the belt. And when the belt is stretched, it's simulating a breath in. The inductance, the distance between those wires, increases, making the signal deflect upwards, and then opposite for the other, for breathing out. There are also something called piezoelectric belts, which have this special rock, crystal, like a quartz. And those produce a very small electrical current, and that can be measured as respiratory effort. We also want to measure alveolar hypoventilation, which is a fancy way of just saying hypoventilation, or not breathing enough. Gas exchange, O2 in, CO2 out. Gas exchange doesn't happen like it's supposed to in an underachieving sense, as we would say for hypoventilation. The way we measure this hypoventilation is with end-tidal CO2, which means at the end of a tidal volume breath, which is when you're just breathing in and out normally, the highest point of CO2 is seen at the end of a tidal breath. This value is typically somewhere between 35 and 45 millimeters mercury. mmHg means millimeters of mercury. And it's all computerized now, but we use that because that was what the old machines would do. It would displace mercury, or you'd have like a little thermometer bulb, and this machine would push the mercury up or down. And because mercury was great at looking at, especially if you dyed it red, and it had a weight to it, and it wouldn't evaporate like if it was oil or a water or something like that. It was really good for blood pressure too. Transcutaneous CO2. Trans meaning through, cutaneous meaning skin or nail, and in this case, skin. It uses a sensor that can be taped, or you can just stick it on somewhere on the skin. But it's a heated electrode, so it needs to be moved every so often, or it will burn the patient's skin. You should look at the policy and procedure for information on your lab-specific rules. A snoring sensor refers usually to a piezo crystal monitor, which, when vibrating, produces a small electrical current that can turn into a signal for snoring when it's placed on the throat, where the patient's neck vibrates the most when they simulate a snore for you. Have the patient snore and feel where the vibration is greatest on the throat. That's a snoring sensor. On the other hand, you can use a snoring microphone. This uses more of a coil, or like a traditional microphone or a spring, to measure the vibration. You still want to put that on the patient's neck, but with a microphone, you could really put that anywhere on the head and pick up a decent signal. Synchronized audio and video recording is a must for the whole study, meaning the video has to line up with the data from the study. If you see the patient move around on the video, you should see where the movement artifact also takes place in the study at the same time. Sometimes actigraphy can be used, which is a device that uses these little things called accelerometers, and that can tell when it's moving. And so those measure little movements. The amounts, or the frequency, how many times these movements happen, and how big the movements are, or the amplitude, those signals can be indicative of excessive movements during sleep time when you put them together with a patient's sleep diary. Or when a patient shows trouble developing a circadian rhythm. Actigraphy is good there. Actigraphy is usually worn for days or weeks, so it's not really something you'd see in a sleep lab for NPSGs. As for any study, an infant's sleep study should run at least 6 hours, but you need to run as long as you can. Unless you have standing orders to only record so many hours on a study, or have a time where you must get your patients up like 5 or 5:30, you should plan to record as long as you can during your shift. I've had studies run 9.5 to 10 hours on pediatric and infants that were easy to hook up, especially for 1-to-1s, tech ratios. It's important to get that much data because infants sleep so much differently than adults. We want to see how much of each stage they can get, and if you cut the study short, you may miss a lot of REM. For some people, they like to wrap the whole head in gauze or a bandana over the electrodes in hopes that you will keep the infant from messing with the electrodes. But I think they have a better chance of grabbing a wire next to their face and pulling on that. In that case, take care of bundling your wires so they are hidden away as possible. EKG sticker electrodes and EEG gold cups may be smaller size for smaller people. However, some labs just use regular sized ones. If you have trouble getting a big sticker electrode on, you can always just use a gold cup electrode. They're all the same thing. I've run a study where I used gold cups for the EEG, the EKG, the chin and limb EMG as well. These wires were 72 inches. That's what Raleigh Neurology uses. Very easy to use on an infant. As always, be very detailed about what's going on while the patient sleeps. Even if it's something like the patient appears to be sleeping quietly in non-REM on their left side. If the patient is sleeping in a bed, make sure it has guardrails so that it doesn't fall off. And as for the other patients, try to accommodate the patient's bedtime for lights out. All right. So that's it for this part, and I believe this unit. Kind of a strange, compact unit, but we're trying to get this stuff so that it's not too much at one time and it's not too little at one time. But I think we'd rather have too little. So these were two interesting conglomerations of information, if you will. All right, do not hesitate to email me or text message me about questions or comments. We'll see you in the next video.